Brought to you by Dr. Joe Audia. Frequently asked questions about neurosurgery and pain management. Questions 86 to 90. Additional applications of peripheral nerve stimulation. I start with a disclaimer. The opinions expressed here are for general information and based on my own professional experience. They are not intended to replace the advice of your healthcare provider on your particular condition.
Question number 86. Besides the treatment of chronic headache, what are some of the other applications of peripheral nerve stimulation?
Answer. Peripheral nerve stimulation, PNS, can play an important role in the treatment of low back pain, peripheral neuropathy, complex regional pain syndrome, pelvic pain, urinary incontinence, epilepsy, and depression. This is by no means an exhaustive list.
Question number 87. What types of low back pain can be treated with peripheral nerve stimulation?
Answer. PNS may be considered for patients with chronic low back pain that is refractory to medical and interventional management, and with no surgical cause identified. Provocative tests on physical examination may provide insight to the origin of the pain. The etiology is often multifactorial. Facet joint pain and sacroiliac joint pain are among the most responsive to PNS. A pair of processes extend upwards and downwards to connect the back of the vertebrae to form the facet joints, which are synovial joints and allow for various motions. The fibrous capsule of the joint is innervated by the medial branch nerve from the dorsal ramus at the level of the joint and one from the level above. The L5-S1 facet joint is innervated by the medial branch of the L4 and the dorsal ramus of L5. Positive facet provocation tests can be confirmed by diagnostic local anesthetic nerve block. Radiofrequency ablation may provide temporary pain relief, but the response diminishes with repeated treatments and a risk of atrophy of the paraspinal multifidus muscles, which contribute to spinal stability and maintenance of posture. After psychological clearance and comprehension of the potential risks, the patient can opt to proceed with the trial. The trial is done in the prone position, under mild sedation and local anesthesia. The needle entry is usually in the upper lumbar region, lateral to the midline. Using image guidance, a special spinal needle is used to pass a lead subcutaneously overlying the junctions of the transverse and superior articular processes. The electrodes extend to the wing of the sacrum, sacral ala, to cover the dorsal ramus of L5. Bilateral leads are placed for bilateral facet pain. Intraoperative testing is performed to confirm paresthesia coverage. The lead is secured to the skin, covered with a dressing, and connected to a trial stimulator. The trial typically lasts 3 to 7 days, after which the leads are pulled out at the office or clinic. If the trial is successful, new leads are placed and a pulse generator is implanted in the upper buttock or the anterior abdominal wall. The sacroiliac joint connects the spine to the pelvis, providing stability and acting as a shock absorber. The nerve supply is extensive and variable, but is mostly from the ventral rami of L4 and L5, the superior gluteal nerve, and the dorsal rami of L5, S1, and S2. Unlike PNS, sacroiliac joint pain is treated with peripheral nerve field stimulation, PNFS, which targets a field of nerve endings rather than one major nerve. The trial and implantation are similar to the techniques for facet pain, but the lead is positioned over the sacroiliac joint and sacral foramen to target the dorsal rami of L5 through S3.
Question number 88. You described the implantation of a permanent PNS. What is the other type of PNS?
Answer. A temporary implantable PNS can be considered for intractable lumbar facet pain. The Sprint percutaneous PNS system is less invasive and the treatment is only for 60 days, but the pain relief can last much longer. Patients with a deep brain stimulator, cardiac pacemaker or defibrillator are not eligible. Waiting for 6 months after radiofrequency ablation gives the nerves time to regenerate. The target medial branch nerve is determined by the vertebra closest to the center of the pain and is identified by image guidance with fluoroscopy or ultrasound. It is commonly L3. The leads are placed bilaterally. The prone position is used and mild sedation may be provided. Local anesthesia is applied to the skin about 2 to 3 centimeters lateral to the midline. The microlead is made of a flexible, coiled stainless steel wire, about the thickness of a coarse human hair. An introducer system consisting of a stimulating probe loaded into a percutaneous sleeve is used to deploy the lead to the target medial branch nerve, just medial to and below the facet joint. It is connected to the pulse generator, and multifidus muscle contraction on stimulation confirms satisfactory placement. Contractions can be visualized on ultrasound, observing the introducer's movement, and felt by the patient. After removing the introducer and sleeve, the lead is secured with a skin adhesive, attached to a mounting cradle on the skin, and covered with a special waterproof bandage. Both leads are connected to a single external generator, which is snapped to a mounting pad that adheres to the back. The patient can use the wireless handheld remote control to adjust the stimulation intensity or to switch it off. It is recommended to apply stimulation for at least 6 and up to 12 hours daily for 60 days. Most regular activities can be resumed, and the external generator can be unplugged and temporarily removed to shower. Bathing or swimming are not allowed. The leads are pulled out at the office or clinic at the end of the treatment. Some patients report satisfactory pain relief for up to 2 years. The procedure can be repeated. Other conditions which can be treated with Sprint PNS include complex regional pain syndrome, post-amputation pain, shoulder pain, and knee pain.
Question number 89. Can you elaborate on the use of PNS to treat pelvic pain and urinary incontinence?
Answer. Chronic pelvic pain can result from gynecological, gastrointestinal, urological, and musculoskeletal disorders. PNS may be explored if conservative methods, including medical and interventional techniques and pelvic floor rehabilitation, are ineffective. The pudendal nerve, which arises from the S2, S3, and S4 sacral nerve roots and provides sensory and motor innervation to much of the pelvic region, is often the target. Stimulation can alleviate conditions such as pudendal neuralgia, vulvodynia, and pelvic floor dysfunction. After psychological clearance, trial stimulation is done under sedation and local anesthesia. With fluoroscopic or ultrasound guidance, a percutaneous lead is placed close to the pudendal nerve and connected to an external stimulator. The duration of the trial is 1 to 2 weeks. If successful, the patient undergoes implantation of a new lead and a pulse generator. There are also reports of successful outcome with a 60-day treatment with the Sprint PNS of the pudendal nerve. An important aspect of pelvic PNS is the application of percutaneous tibial nerve stimulation, PTNS, to treat overactive bladder and the associated symptoms of urinary frequency, urgency, and incontinence. Patients who do not respond to standard management may be candidates. In the United States, about 40% of women and 30% of men experience overactive bladder, which may occur independently or be associated with conditions like diabetes, multiple sclerosis, and pelvic muscle weakness. The frequent urge to urinate can be very disruptive to sleep, social engagement, and quality of life. Many pharmacies and department stores have large sections with incontinence pads, pants, and products. The tibial nerve travels to the sacral nerves, which control the urinary bladder and pelvic muscles. PTNS is a non-surgical office-based procedure, usually done with the patient sitting comfortably, in a chair or a recliner. After cleaning the skin, a 34-gauge stimulating needle electrode, similar to an acupuncture needle, is inserted 2 centimeters behind and 5 centimeters above the medial malleolus of either ankle. It is angled 60 degrees upwards and advanced to a depth of 2 centimeters and connected to a handheld stimulator. A sensation of tingling or flexion of the big toe confirms satisfactory electrode position. Stimulation is provided for 30 minutes and the needle is removed. Treatment is performed weekly for 12 visits, but it may take 6 to 8 weeks of therapy before noticeable improvement in bladder function. Some patients require once-a-month maintenance treatment.
Question number 90. What type of peripheral nerve stimulation is used to treat epilepsy and depression?
Answer: vagus nerve stimulation, VNS, can be used to treat epilepsy and depression. It is the 10th and the longest cranial nerve and extends from the brainstem to the neck, chest, and abdomen. It controls autonomic functions including lowering of heart rate, aiding digestion, and maintaining the respiratory rate. Vagus nerve stimulation increases blood flow to some areas of the brain and lowers neuronal excitability, thereby reducing seizure frequency and intensity. It is FDA approved for patients 4 years of age or older with medically resistant epilepsy. Activation of the parasympathetic nervous system by VNS triggers the release of mood-enhancing neurotransmitters like serotonin, norepinephrine, and gamma-aminobutyric acid, GABA, and is a potential treatment in adults 18 years or older with intractable depression. VNS can be delivered through implanted or non-invasive external devices. Patients or their legal guardians must receive a comprehensive explanation of the treatment, the rationale, potential risks, and realistic expectations. The vagus nerve stimulator is typically implanted under general anesthesia, with the left vagus nerve as the target because the right vagus nerve is more likely to cause slowing of the heart. In the supine position, the surgical field is prepared. After applying a local anesthetic, a skin incision is made across the front of the neck and another is made in the anterior chest wall below the clavicle. The neck dissection is continued vertically to expose the vagus nerve located between the carotid artery and the internal jugular vein. The spiral electrodes at the distal end of the lead are wrapped around the nerve, and the insulated lead wire is tunneled to the chest wall incision, where a small subcutaneous pocket is created for the generator. The lead is connected to the generator. Testing is done to confirm satisfactory connections, and the incisions are closed. Follow-up appointments are important to start or adjust the stimulation. Patients with epilepsy are given a magnet, which they or caregivers can use to activate additional stimulation when there is an aura or to interrupt an actual seizure. Non-invasive vagus nerve stimulation, NVNS, uses an external device to send electrical impulses to the vagus nerve, often through the auricular branch in the ear. Electrodes are placed on one earlobe and attached to a handheld generator. The treatment is for 15 minutes daily, and it can be self-administered at home by the patient. Non-invasive VNS devices have a lower voltage output, which may make them less effective than implanted devices, and they require regular use to sustain benefits.